Hi everybody, my name is Deandra Bacon and today we will be talking about chronic kidney disease, also known as CKD. This is something we will see all the time in primary care, and the earlier we catch it, the more we can do for our patients. As we go through this presentation, I will mention a fictional patient, Mrs. T, who represents the kind of patient many of us will see every day. My goal is to make CKD feel a lot less intimidating and help you understand what's actually happening inside the kidneys and why early detection matters. Let's start with why CKD is such a big deal. CKD is any kidney abnormality that lasts longer than 3 months. It affects around 37 million adults in the US, and what's most shocking is that most of them don't even know they have it. The biggest drivers are diabetes and high blood pressure. As shown as this figure right here, 44% diabetes, 29% makes up high blood pressure. We catch a lot of CKD in primary care. Our case patient, Mrs. T, has both conditions. This puts her right in the high risk category. CKD matters because it does increase the risk of heart disease, disability, and can cause early death. So catching it early is very important. Before chronic kidney disease makes sense, it helps to remember what healthy kidneys do. Each kidney has about 1 million tiny filters. These are called your nephrons. These nephrons are the basic functional unit. They help clean your blood, balance fluids and electrolytes. They help control blood pressure, and they also activate vitamin D. They also release hormones, erythropoietin, to help make red blood cells, renin, and vitamin D. So when the kidneys start to fail, you can imagine how all these different body systems can get thrown off balance. So etiology across the lifespan. CKD doesn't look the same across ages. In kids, it usually is due to congenital problems or genetic conditions. In adults, it's more about diabetes and high blood pressure, which are the main factors. Also, it can be autoimmune causes. In older adults, age itself becomes a risk factor because kidney function naturally declines and medications can be harder on the kidneys. For our case study, Mrs. T, she had years of uncontrolled diabetes and hypertension slowly has damaged her nephrons. So now we're going to talk about pathophysiology. I kind of summed it up here. So what is actually happening in chronic kidney disease? It starts with injury to the nephrons from things like high blood sugar, high blood pressure, or inflammation. The remaining nephrons try to work harder to make up for the loss, and this process is called hyperfiltration. This works for a while, but eventually this extra pressure damages the filters even more. Then scar tissue forms, inflammation builds up, and then you have fewer nephrons that are left to do the job. That's why Mrs. T EGFR, which stands for estimated glomerular filtration rate, measures kidney function, is down to 38. Her kidneys don't have enough functioning units left. Remember, a typical EGFR is typically 90 or higher, though it naturally declines with your age. And EGFR below 60 for 3 months or more can indicate kidney disease. So I inserted this diagram just for visual learners. This just shows the kidney and some of its structures. It's showing glomerular function in the process of reabsorption and secretion. As you can see here, you see it starts with the proximal convoluted tubule and it ends with the collecting duct. And you also can see where active transport and passive transport is taking place. Molecular and cellular mechanisms. So zooming in more, we have several molecular processes that keep damage going. The RAS system, the renin-angiotensin-aldosterone system. This gets overactivated, which raises blood pressure and adds more strain on the kidneys. You have inflammatory chemicals like interleukin 6 and TGF beta, which stands for transforming growth factor, create scar tissue, and you also have oxidative stress. And this, think of it like internal rust. This damages the cells lining in the kidneys. So even if we fix the original cause, these internal processes can keep the disease moving forward. Right here, I just inserted a little picture of the RAS system just for visual learners. I think it was pretty interesting how they depicted it here. Staging and progression. CKD is staged based on the EGFR from stage 1 all the way to stage 5. Stage 5 is basically kidney failure. One of the earlier signs that we often notice is protein in the urine, albuminuria, and this tells us that the filters are damaged. Most patients, including our fictional patient, Miss T, she don't feel symptoms until they're already in about stage 3. That's why screening is so important. CKD is often silent, so make sure you do early screening. It's essential. Here I inserted a picture just for visual people, the stages of chronic kidney disease, how it goes from normal function to mild loss, to moderate loss, to severe loss, into kidney failure, and how the kidney progresses and looks over these stages. So let's talk about clinical manifestations. As CKD worsens, your symptoms slowly build. Early on, people feel tired. They're also experiencing nocturia. They're getting up to pee more at night. Later on, you start getting toxin buildup. This causes swelling. Also can cause nausea, itching, appetite changes, and also can cause cognitive changes as well. You can also see anemia systemically because the kidneys stop making erythropoietin, and it also can cause bone problems from calcium phosphate imbalances. Mrs. T, she reports fatigue and also ankle swelling, and this fits the picture perfectly. So with any disease, we are going to look at the diagnostics. When we evaluate chronic kidney disease, we are going to look at labs like BUN and creatinine. BUN is the blood urine nitrogen, and usually these are increased with people that has chronic kidney disease. You also will have a decreased EGFR, and EGFR is used to understand kidney function. Also, they have urine tests. Usually your urine will have a lot of protein in it, and it also can have hematuria. We can do kidney ultrasounds. This helps us see structural changes like echogenic kidneys. In Mrs. T case, she had an elevated albumin to creatinine ratio, and this was an early sign that her chronic kidney disease were progressing and confirming that she had CKD. Let's talk about treatment. Treatment is all about slowing things down. We would like to keep the blood pressure below 130/80, and this is huge because the main two causes of chronic kidney disease is high blood pressure and diabetes. We also can use ACE inhibitors or ARBs, which stands for angiotensin receptor blockers. These are a go-to because they reduce pressure inside the kidneys. In diabetes, also the goal is to have an A1C below 7%. We also have SGLT2 inhibitors. These have become major game changers in protecting kidney function. So SGLT2 inhibitors are a class of oral medications that primarily lower blood sugar with type 2 diabetes by causing the kidneys to excrete excess glucose in the urine. We also work closely with the diet. We will want low sodium, moderate protein, and fewer processed foods. And of course, avoiding medications like NSAIDs are essential. For Miss T, we started her on lisinopril, and she's working with a dietitian, and these are important first steps. Cultural and holistic considerations. Chronic kidney disease management has to be realistic and it has to be personalized. Diet changes are tough and they need to fit someone's cultural food preferences. On top of that, people may be dealing with financial stress, transportation issues, or in general, fear of what CKD means long term. So, as nurse practitioners, we look at the whole picture: physical, emotional, social, and cultural. Mrs. T, in this case, she felt nervous about changing her diet, so we worked with a dietitian who understood her cultural background. Just make sure that we provide emotional and social support, and that's very important. Mrs. T, our case study. Mrs. T is a 52-year-old African American woman that has long-standing diabetes and hypertension. She came in feeling very fatigued, swollen, and just waking up several times in the night to urinate. Her lab showed an EFGR of 38 and significant protein in her urine. Her creatinine was also 2.5. This was confirming her stage 3 diagnosis of chronic kidney disease. We started evidence-based interventions, and we refer her to nephrology to prevent further decline. Our plan also was to make sure we optimize her blood pressure and her glucose control. When we look across major guidelines, most of them agree on the big picture. The Kidney Disease Outcomes Quality Initiative guidelines emphasize strict blood pressure control. So this is blood pressure less than 130/80. The ADA guidelines strongly recommend SGLT2 inhibitors for diabetic patients with CKD, as we talked about earlier. And the CDC focuses on screening high-risk groups. Mrs. T meets criteria for all these recommendations, especially for the SGLT2 therapy. In any disease process, prevention and early intervention is the major key. Prevention is where we make the biggest impact. We have primary prevention. This means we are managing blood pressure, we're managing diabetes and different lifestyle factors before chronic kidney disease develops. We have secondary prevention. This means we're screening high-risk patients every year. We're doing annual EGFR, and we're also doing urine screening. We have tertiary prevention. This is about slowing the CKD progression once it's already there. So things like your ACE inhibitors, your diet changes, and glucose control. We also have ARB therapy and education. Mrs. T's story, it just shows how early nurse practitioner involvement can really make a difference. NP-led screening prevents CKD progression. So make sure we're doing early detection in our patients. The role of the nurse practitioner. Nurse practitioners are on the front lines of chronic kidney disease care. We screen patients, we order labs, we manage medications, we perform risk assessments, and we educate them on overall lifestyle changes. We use motivational interviewing to help patients set realistic goals and help stay engaged in their health. We coordinate care with nephrologists, dietitians, and social work to address the whole patient. We advocate for culturally competent care. So we look at the whole patient, not just their kidneys. So to wrap things up, chronic kidney disease or CKD is a slow progressive loss of kidney function over time. Instead of happening suddenly, it does develop over months to years, and many patients don't notice symptoms early on. The main causes are diabetes and hypertension, which damage the nephrons through high blood sugar and increased pressure inside the kidneys. Other risk factors include aging, you have cardiovascular disease, obesity, family history, and chronic NSAID use. From a pathophysiology standpoint, CKD begins when the glomeruli and tubules become inflamed or scarred. As more nephrons fail, the remaining ones work harder, eventually wearing out. This leads to waste buildup, fluid retention, electrolyte imbalance like high potassium, and metabolic acidosis. CKD is staged from 1 to 5 based on the EGFR. Early stages often have no symptoms, but by stage 3, patients may notice fatigue or swelling. Stage 4 involves significant decline, and stage 5 is kidney failure, which can require dialysis or even a transplant. Clinically, patients may experience edema, shortness of breath, nausea, muscle cramps, or cognitive changes. Common lab findings include elevated creatinine, NBUN, anemia, also abnormal calcium and phosphate levels. Treatment focuses on slowing progression, so you want to control blood pressure and blood sugar, use ACE inhibitors or ARBs. You want to limit sodium intake and avoid nephrotoxic medications, and managing your anemia or any electrolyte issues you may have. Advanced stages may even require dialysis. As a future nurse practitioner, my role is essential in early detection and long-term management. I'll be monitoring labs, recognizing early trends, adjusting medications, teaching patients how to manage diabetes and blood pressure, and just helping them understand what the actual numbers mean. I'll coordinate referrals to nephrologists, dietitians, and just overall support my patients' emotional need and help with their lifestyle changes and complex care decisions. Using our earlier example with our patient, Miss T, she had an EGFR 38 and she may just feel a little extra tired. But as a future NP, catching that early and helping her improve her glucose control and help managing her blood pressure can slow the disease and overall improve her quality of life. And this concludes my presentation. I hope you enjoyed it and I hope you learned a little bit more about chronic kidney disease. These are a list of my references here and I hope you guys enjoyed. Thank you for listening.